Thanks to everybody for joining us so bright and early this morning. Before we get started, we're going to set the stage by showing a video that was created for the Milken Institute's inaugural Public Health Summit earlier this year in DC. Can we tee that up?
From the dawn of civilization, global life expectancy remained essentially flat until the 19th century. Then, in what may be the greatest accomplishment of human history, people's lifespans more than doubled. Soon after, per capita GDP more than quintupled. Advances in public health and medicine have driven as much as half of all economic growth. What do these advances mean for you and me?
In 1900, 1 in 5 children died before the age of 5, and people lived an average of only 31 years. Today, childhood mortality is extremely rare, and worldwide life expectancy is 71 and climbing.
Vaccinations have largely eradicated many of the leading infectious causes of death from a century ago. Antibiotics have reduced pain and suffering and saved millions of lives that would otherwise have been lost to bacterial infections. The percentage of Americans who smoke has dropped from 42% to 18%.
This decline has saved 8 million lives and extended U.S. life expectancy by 2 years.
But we still have a long way to go. More than 1 in 3 American adults are obese, and obesity is the leading factor in the growing burden of chronic disease. Drug-resistant bacteria are responsible for 2 million illnesses annually in the U.S. alone, and more than 23,000 deaths. The increasing interconnectedness of our world has many benefits, but it also leaves us more vulnerable to the spread of contagions, which do not respect international borders. Decreased vaccination rates have resulted in outbreaks of preventable diseases.
However, there's tremendous hope for the future.
The Welch-Rose Report of 1915 established the blueprint for public health education in America and helped galvanize support of this crucial mission. A century later, it's time to reaffirm our commitment to public health,
to make prevention and wellness a priority,
to combat infectious diseases that are overpowering our best defenses, and to relegate cancer, heart disease, diabetes, and other preventable chronic diseases to the history books. Let's not pass the social and economic burdens to the next generation. Let's commit now.
So as the video shows, public health advancements over the past century or so have extended lives and boosted prosperity across the globe, with great efforts around immunizations and tobacco reduction and infectious disease control. Yet there's so much more to be done. It's estimated that every health dollar we spend, 90 cents of that dollar goes to treating disease, and only about 10 cents goes to prevention and research. And as the video told us, 1 in 3 American adults is now obese, and obesity is the leading factor in the growing burden of chronic disease. So how can we duplicate the successes of the past and help tackle these new challenges? We have an esteemed panel today to help discuss these issues of health experts and industry leaders. First, down here to my far right, is Dr. Lynn Goldman, the Dean of the Milken Institute School of Public Health at George Washington University. To my immediate right, Harry Leiter, Chief Medical Officer of Walgreens. Here on my left, Carmen Navarez, Vice President of External Relations and Preventative Medicine Advisor for the Public Health Institute. And down there, Dr. Winston Wong on my far left, Medical Director, Community Benefit from Kaiser Permanente. Doctor. Isn't that in Fletch? I am not a doctor. I am Ryan Shadrick Wilson. I'm the Chief Strategy Officer of Partnership for a Healthier America. We're a nonprofit based in DC that aims to fight the obesity crisis and to help make the healthy choice the easy choice for all people in all communities. And we do this by working with companies, about over 200 of them, and celebrities, we're at about 70 of them now, and our honorary leadership, which we're fortunate to have First Lady Michelle Obama and Senator Cory Booker and former Senate Majority Leader Bill Frist. So I think about these issues every day, and I'm so pleased to be here. But we recognize that here at the Milken Global Conference, there are folks from all sectors, a lot of folks from the finance industry, and I think it might be helpful if we start out saying, sharing with the group here why they should care. What is the business case? Aside from the moral imperative, why should we invest in public health? Winston, would you like to take that?
Well, I think if you look at not only life expectancy, but human productivity, it's pretty much associated with not only keeping people alive, but keeping them as productive throughout their adult lives and being the leaders of their household. As investments go into supporting families and neighborhoods and communities where they can thrive, you basically find a community that's one that's productive, that has a lot of opportunity to create wealth for the commons. So it's a pretty direct line between the investments we make in terms of assuring that people have a good start to life and they maintain that opportunity in terms of their education that's put in front of them, as well as when they go into their professional and working lives.
Yep, sure, Lynn.
I think we need to also think about our competitiveness with regard to other nations. If you look at slide number 2, when in the video, you could see how life expectancy has been rising over time, and you can see that actually, when the slide does come up, that we have continued to see that rise in life expectancy, but unfortunately, that the amount of rise for the United States has been less than other countries that belong to the OECD. So why should that be so, that we would not be achieving the same gains in life expectancy as other OECD nations? And if you put up slide number 3, we similarly see a very disturbing pattern with regard to infant mortality in the United States, which I, as a pediatrician, of course, am concerned about simply because of the well-being of infants. But we also know that this is an indicator of the kind of start in life that people have, which has a tremendous impact on economic productivity of a nation, and that our infant mortality should be lower than the infant mortality in places like Slovakia, Hungary, Poland. Why is that? And then finally, in slide 4, which I think is also worth looking at, this is not because we fail to invest in health. We pay more per capita easily than any other country on the planet. We're the bar on the far left in this graph, and the red bar in the middle is the median per capita expenditure in health among all OECD nations. So I think it's fair to say that we are not receiving the health bargain for the investment that we're making. And those are costs that come out of all of our hides, whether they are paid through public insurance programs or private insurance programs that people receive through the workplace. Even at my university, George Washington University, we see the costs continuing to go up and up and up for health insurance. Each and every one of us is adversely impacted by these costs, but yet we're not receiving the benefit that we should be receiving in terms of health and productivity of our people.
Yeah, I wanted to take a slightly different angle, because the question was, how can it make an economic difference and lead to prosperity from a corporate standpoint? Lynn and I were talking prior to the session kicking off. May is Mental Health Month, and statistically, more people have a mental health illness or condition than heart disease and diabetes combined. The prevalence is about 1 in 5 in the United States. You know, the most common, of course, is depression, but anxiety is right behind it, and there's other problems as well. And if you think about your workplace, on any given day, if 1 out of 5 people either aren't showing up or calling in sick, or more commonly come in but aren't really doing their job because they're so anxious and they're depressed, and there's such a stigma around getting help and getting treatment in this country, and there's not parity for the treatment, there's a direct impact on productivity. Estimates are every dollar spent in that area quadruples in terms of return on productivity. So we think a lot about physical illness and obesity, which is a huge problem, but for employers, having their employees healthy of body and mind is good business. It's not just the right thing to do.
So I want to put a slightly different slant on it and just do a quick dollars and cents. We have an investment here. We're talking about $3 trillion, the U.S. economy, that goes into health care. That's more than 17% of the GDP. And 75% of that is spent on conditions that are completely preventable. And so I think that that's part of what we want to talk about is what are some of the, what are some of the antecedents and what are some of the interventions that we think could help us get better value for that $3 trillion, because that's a lot of money. Healthy people learn better, they work better, they play harder, and it just makes a better community in which in which we're hoping to see going forward.
It's really compelling. But if public health is so linked, so definitively linked to our prosperity, why isn't there greater awareness? Why aren't we doing more on the prevention side?
Well, that's a really good question. I'm glad that you brought it up. Back in 1854, when John Snow took the pump handle off the pump, where the cholera was originating and causing this terrible number of deaths in London. I don't remember what the mortality is. Somebody else probably does. You saw a quick result. So communicable disease, infectious disease is really quick. You can see a result in a very short amount of time. For conditions like mental health, for conditions like chronic diseases, you don't see that kind of quick turnover. It almost looks like it's, like it's a bad investment. Right. But in fact, when you look at it over time, you get very good return on investment. Look at the tobacco tax in California, 25 cents a pack, 1988. It took 11 years for us to see a decrease in the number of lung cancers. 11 years. Actually, it was a decrease in the rate of lung cancers. And that's not a short period of time. And how many people would even know that 25 cents per pack would produce such an impact, and over time really saved us billions of dollars? But it takes a while for these investments on very wicked problems. Preventable diseases don't have one cause. They have multiple causes. So these are wicked problems. And when you're trying to figure out how to make the right investment, it's not a straight shot. Mm-hmm. And that's part of the reason that it's a little, it can be hard to get the message across about why public health is important.
I think there's an economic reason too. In my career, I've worked for 3 health plans in the past, sometime before joining Walgreens. The health plans, for those of you that are not fully insured, who work for organizations not fully insured, where they take the financial risk of paying for the medical bills, the medical claims. The horizon of a health plan on ROI, I'm kind of building on your point, is 18 months to 2 years. So any investment in prevention that doesn't prevent a hospitalization or an ER visit in 18 months or 2 years is not deemed by a payer to really be a good investment. Employers, many of them, have a longer term point of view and have an opportunity to make slightly longer investments, but really our payment scheme here in the U.S. for healthcare is not aligned with making long-term investments in prevention outside the public sector, and that's a real fundamental problem. I'm not advocating necessarily for a single-payer system because UK has its problems too, as do other countries, but the incentives fundamentally are not well aligned for the long-term investments, Carmen, you're talking about.
Mm-hmm. Lynn?
And perhaps to put up another slide, number 7, to think about what is actually killing us. What are the diseases that are killing us? And unfortunately, and this is for women, but for men it's a very similar picture, it's almost everything you can think of. It's maternal conditions and childbirth. Our women are dying more than women in other OECD countries. But it's also nutritional problems, injuries, drug and alcohol related problems. It's also cardiovascular disease and other non-communicable diseases like diabetes. And so when you sum it up, there's an enormous differential, but it has many components. And one thing that all of those components have in common is, I think, what we just heard, which is that the prevention is a very long-term proposition. This is not a matter of, we give you a vaccine and you're not going to get diabetes tomorrow. This is a matter of, behaviors that we have each and every day over many years that contributes to diabetes, to heart disease, to hypertension, and also to pregnancies that are more difficult, to childbirth that's more difficult. And it's not that we don't know what to do. It's amazing to me how people like me and a couple of other people on the panel who've been in public health our whole careers, we're very good at developing the dozens of things that need to be done by public health agencies. We can give that to you, chapter and verse, here are all the things. But it's that there isn't the societal support for it, and that the entire healthcare system is so much torqued toward kind of an end of the pipe solution. It's almost perverse. It's almost that the motivation in the healthcare system has been to allow us to become ill so that we can receive these very expensive interventions that are very profitable to the healthcare industry, and there haven't been the incentives in the healthcare industry to keep us well. And I think one thing I'd like to hear about some of the other panelists is how they see some of those incentives beginning to work out, because a lot of us have been trying to find ways, can we get both the public and private healthcare industry to be incentivized to actually keep us healthy, and because that has not been the case in the past.
Right.
So, Ryan, the metaphor I like to think of when we typically frame public health, particularly in the United States, is the umpire in baseball. The best umpire in baseball is hardly anyone pays attention to because the game is going smoothly. But as soon as the umpire makes a wrong call, everybody's throwing peanuts on the field. That's kind of what public health is. It sits in the backdrop, and people don't pay attention to it until something goes wrong. And so when we see things like the headlines, typically around public health, are Ebola virus or Zika virus, and everyone then starts raising their arms, getting very excited, and where's our public health system? Well, those are just blips on the screen. Public health, typically, when it does well, no one notices it. No one would have noticed those trend lines that were mentioned in the video if, in fact, we didn't do the right things. It's because public health has made these investments that we've been able to see all the fruits of a longer lifespan and productivity. To the point that both Harry and Lynn made, I will tell you that Kaiser Permanente, we have about 10.2 million members right now across the country. And our typical churn, as we call it, the number of people who drop in and out of Kaiser Permanente as an insured company, is very small. It's about 5% every year, which is very different than most health insurers. Yeah. And because of that, we've been able to actually invest in upstream prevention as the mainstay of what Kaiser Permanente stands for. So people stay with Kaiser Permanente through generations. It's not atypical for us to say and talk to patients, oh, my kid, my grandchild, et cetera. And because we have this framework, we can typically think about ways to support communities, patients to adopt better behaviors, to support systems that enable them to have stronger environmental conditions in which they can thrive and not necessarily become the expensive consumers in healthcare that we see in other parts of the health insurance system in the country.
I have another thought about that somewhat ties this together. This is really a community enterprise. So public health is not the work that, that those of us sitting up here do. Public health is really very much turning into a community enterprise. I mean, we recognize that, if you tell somebody to walk more, but there's no place to walk, there's a problem. And you can't solve that out of public health. You have to solve that by working with the people that are developing the communities. Make sure that there's sidewalks. Make sure that the kids can ride bicycles on the street. Make sure that there's a park in the neighborhood. Make sure that when you look at redeveloping communities, that those are the kinds of considerations you keep in mind. So, when, a little bit about the environmental, when you talk about what Kaiser is interested in, every time I go to Kaiser, there's a Thrive sign that says walk up the stairs. There's there's another Thrive sign that says eat more fruits and vegetables. And I can do that while I'm there. But if I go home and there isn't any place I can buy fruits and vegetables, then I'm kind of up a creek without a paddle. And I think that's what we mean when we talk about a community enterprise. It's really got to be a partnership, and everybody in this room has a role in that.
Yeah. Well, Lynn, you said that the incentives aren't really in place for us to make more progress and to move the dial. It sounds like for Kaiser, there has been an incentive because you have folks stay with you for longer than a lot of companies do. What about, I mean, what we hear a lot when we talk to big employers across the country, at my organization, we're trying to push employee wellness programs, is that there's too much turnover. They're not going to see the benefit of investing in health, particularly young employees, because they've got 10 more jobs they're going to hit before these costs kick in. What do you say to that?
You know, I think that we can make the business case. I think we can make the business case. I mean, I have another slide, actually, number 25, to put up.
Of course you do.
Which shows actually what the water in Flint, Michigan looked like a couple of months ago. And here's an issue that, you know, for years and years and years, we've known how to make the water safe. We heard about the cholera in London, and we know that by making water safe and food safe, that's much of how we've seen gains in life expectancy. And here we have a community where not only lead, but also Legionella, we're in the drinking water. And this woman is bringing this water in to try to get this addressed. And what didn't happen in this community and needs to happen in communities across the country is, one, for our drinking water systems and other basic public health systems not to be invisible. This needs to be visible. People need to understand that these systems only work and that they are maintained, but also that the employers in the community, that the businesses in the community who were the first to become aware of this problem, that they actually switched to other sources of water because this contaminated water was interfering with their manufacturing processes, it was ruining the equipment in the hospitals, that we really need to have mechanisms to bring those employers together to say, how do we jointly help to address this problem in our communities? Because if we're leaving it to a public service context where it's simply up to state and local government to take care of these things, when we know that the resources that have been made available to these agencies have been dwindling over the years, or if we leave it up to just the members of the community who, after all, are the employees of the companies to try to do something about this. These are issues that are not going to be addressed unless we join together, but we need to become more creative about how we finance these issues, whether it's the water in communities, the parks, the ability to have opportunities for exercise, better food. These are issues that we need to work on together. They're not going to be addressed just by, you know, public health agencies alone or hospitals alone.
We have, your question's really a good one. We have about 240,000 employees here in the U.S. Walgreens is actually a Walgreens Boots Alliance now, which is a global company where there's more like 340,000 employees. And it's really a challenging problem because most of our employees are actually out in retail stores or Walgreens stores where some of them are clerks without a college education, and then who are working their way up in the world, and then you've got pharmacists who are professionals, so you have very diverse needs around employee health. And I think the answer, at least for us, and my belief is that a big value proposition really is employee loyalty. I think millennials really care about a healthy environment, to your point. They care about a healthy workplace. Companies that have put out healthy food and made it easily available, that make exercise easy to do, that put in gyms. We have one at Walgreens at our corporate headquarters that's phenomenal. People want to be there because they feel good about the values of the company and that it is a healthy place to work. So I think for young folks, it's less about preventing diabetes 10, 15 years down the road because that's hard to do the ROI for an employer. But it's really around that loyalty of young folks feeling good about working for that company. For middle-aged employees, then I think there really is the direct health issues of trying to prevent people from getting sick and all the stuff we talked about earlier.
Yeah.
But a culture of wellness, I think, does have a loyalty factor for companies, especially in areas that attract a lot of millennials in technology and healthcare.
Yeah, I mean, you certainly see companies competing on health now
That's
in
correct.
the Bay Area.
That's right, exactly.
To get those employees, and in certain other pockets of the country. But is that something that you think might start happening across the board for the hourly worker? I mean, companies starting to compete that way?
I think as the unemployment rate has gone down, as it's harder to find talent, even at the lower level positions, I think there is going to be more of a competition around retention, especially now that it is harder to find employees. So I think we're at a good time for that.
Yeah. And Carmen and Lynn, I think I heard you saying a little bit of the same thing, in that you are advocating more cross-sector collaboration at a community level, public sector, private sector coming together. Is that not happening?
You know, it is happening.
Happen anywhere?
No, it happens all the time now, but it's a little hard to see. It doesn't have a good sound bite yet. It needs really good sound bites. We need your help on that. I think that we have a hard time lifting those things up and saying, see, we did that, we're public health, we did that, because it isn't just us. It really is a partnership. It's the partnership with the developers, it's the partnership with the corner stores. When you get corner stores, you know, you go in and you start working with them and they start putting in more fresh fruits and vegetables, and they start moving back some of the less nutritious foods. And you know, when neighbors start going there and starting to purchase those, it's culture change, and culture change isn't something you can put your finger on and say this happened on that day and it caused this impact. These are things that you see over time. So I think that you know, it is really something where we recognize and we really respect and honor the fact that it's not just us. What we do in public health is we put our finger on something, we start to collect data about it, we look at it, we analyze it, we name it, we propose some strategies, but the people that really change the health status of people across the world around this country are the people that are in this room. It's a partnership. It's everybody's work contributes in one way or another, positively or negatively, and that's where the change happens.
Right.
You know, right, it reminds me of a very interesting phenomenon that we have in the United States, and I'm going to bring it very much where we are. Here in Beverly Hills, I don't know the exact figures, but the life expectancy, I assume, in Beverly Hills is probably well over 80 years of age. But if we go about 2 miles east of here, the life expectancy radically drops, about 7 years difference. We see this across most communities in the country. Radical drops just on a mere 2 miles, a mere 2 stops in the metro. And what we're trying to do now is to think about that intentionally in terms of where the investments really need to be made. And it's very interesting, too, that if you increase the investments in low-income neighborhoods and thus increase the life expectancy in a low-income neighborhood, the overall community, including Beverly Hills, the life expectancy starts to go up. So we have to deal with the issue of disparities in communities as well, as much as the phenomenon of having slower trends and improvements in public health. Until we deal with the disparities and be intentional about creating health equity across different communities, we're probably not going to make the great leaps and bounds that we did in the early 20th century.
Yeah. I've heard that before, that the #1 predictor of health outcomes is zip code. Is that still the case?
Well, I think it is a tagline for people to realize that zip code means more than genetic code when it comes to life expectancy across communities, particularly in the United States, where we have lopsided investments. So Cedars-Sinai here, which is one of the world-renowned medical institutions, we're spending literally millions of dollars in the last few weeks of a person's life, where we don't spend millions of dollars in the child that's living in the barrio here in East LA. So we have to kind of even out the investments that occur across communities.
I mean, I very much agree with that. I also think another disparity, and actually it's something that's happened, it's unprecedented in our history, and that is we actually see a decline in life expectancy in one group in this country just during the last couple of years, and that is for whites who are working class. And those declines have to do with a combination of drug-related deaths They have to do with opiate overdose and other overdoses. They have to do with alcoholic liver disease. And they also have to do with some increase in chronic disease. And what we're seeing is a constellation of increases in a number of health issues that are probably mental health related, perhaps stress related, in the lives of some of these populations. Stress, by the way, has a lot to do with the zip code related gradients in mortality as well. It also has to do with the obesity epidemic and the fact that with increases in obesity, certain populations are especially impacted, not only seeing sharper rises in obesity, but also having less access to medical care to take care of the consequent diabetes and other, if you may, side effects of being obese. If you're obese and your diabetes is under control, you're at much less risk than if you're obese and you have out of control diabetes, out of control hypertension. And so we're very concerned about what's happening in this population in terms of what does it mean in terms of how we should be addressing their health. And we haven't particularly had strong approaches. I have a feeling many of those folks may work in places like Walgreens and other places, but is it enough to have a health program? Do they subscribe to it? Do they go, if there's a gym, do they go to the gym? Do they use it? What do they know about diet, what to eat?
So this is a great segue. I'd love to talk about a way we're kind of tackling this not only with our employees but with our consumers. So we have a program called Balance Rewards for Healthy Choice. This is not an infomercial, it's just an interesting case study. How many people here have a Balance Rewards card from Walgreens? And how many people here have a reward card from CVS? You can leave. No, so they're a good company. We're good competitors. But anyway, 80 million Americans have this Balance Rewards card from Walgreens. It's one of the largest loyalty programs in the country. And it used to be you got points for refilling your prescriptions or getting immunizations. But we had this idea 2 years ago to start rewarding our consumers, and this works as well for our employees, for walking, exercising, to your point, to tracking your weight. If you have diabetes, for tracking your sugars and uploading it to our website, to your website, because you own the data, via glucometers that now can capture the data and transmit it. Blood pressure cuffs can be enabled to upload data. And what was really cool is we make it so easy that it takes about 20 seconds to set up an account at the Walgreens website and hook in your Fitbit or your Jawbone or your scale and start logging your data. And then we started giving people Balance Rewards points, which translate into money, credit, 1,000 points is a buck. And you get points for walking every day. So right now, anybody who's in our ecosystem, if they're using a Fitbit or a Garmin or whatever device, or logging their food with MyFitnessPal or Lose It, or weighing themselves every day, are earning points. Because of this ecosystem with big partners like MyFitnessPal and Withings and Fitbit and all that, and this incentives, we currently have about 1 million people on the platform. And the early results are really intriguing. We have the average weight loss for people who are tracking their weight is 3.3 pounds, which doesn't sound like a lot, but across a large population, that's actually a big deal. 1 in 6 are losing 10 pounds when they're tracking their data. They're more adherent to their medications. But here's the point that's really, really interesting from a sort of population health standpoint, trying to make a difference with big populations. Any program that you start, traditionally, at the end of a year, for 100 people that start a weight loss program or a diabetes prevention program or a program for hypertension, at the end of the year, the typical number that's still participating, keep me honest here because some of you have built these programs, maybe 20%.
Yeah.
So what we're finding is because of the incentive to track your data, and it's so easy, we have 70% participation at the end of the year, which is really phenomenal.
Yes.
So I think the idea is we can't get everyone to go to a gym. But if we can get people excited about wearables and tracking their data and incenting it, and then providing them with some coaching online, we have like a pharmacy chat function and telemedicine. We've used technology and incentives to try to do something at scale. So that's probably the most exciting thing I see, at least we're working on today, is leveraging technology rewards and distant coaching to change behaviors. Pretty cool.
And it doesn't just change behaviors, it changes culture.
That's right.
Because you really have something that everybody starts to partake in.
Right.
And people start, comparing each other. And whether you have a friend online
There's
that
a
you are
competition.
comparing with, there's a competition
Yeah, that's
going on.
right.
And people are becoming more and more aware. And you can see that change in companies that have attractive wellness programs. So one of the clinics that I work in instituted a wellness program a few years ago. And what I saw in the difference in the workers was amazing, just really astounding. Lunchtime, everybody's out and they're walking.
Right.
Up and down the parking lot, which doesn't sound exciting, but they're all doing it. And that is exciting, because just a few years ago, they were sitting in the lunchroom eating, Doritos and Cokes and things like that, and that's how you spent your lunchtime.
Is that because some incentives were put into place to
in that
inspire
particular
folks
program,
to behave like that?
There weren't incentives. There actually was the
culture shift.
Yeah, it was the culture shift. It was just a really strong sense of, let's be part of something bigger.
I think this whole issue of workplace wellness is an example of the nexus between investing in individual behaviors and creating community standards or expectations about how we invest in population health. And those that are in viable jobs, this is a great opportunity. Now, having said that, we know that there's large swaths of communities that don't have strong employers like Walgreens and other organizations. And we need to kind of look at how we intentionally get to a place where there is a blurred line between investing in your Fitbit versus things that we know that as a community we need to invest in. Technology has great promise. I mean, I've heard also for the fact that some companies are dealing with asthma inhalers, and they have a tracking device to see if in a given geographic area, whether more individuals are using their inhalers more frequently than other geographic areas, and then use that as a public health tool to identify segments in which something is going wrong here, whether it's dust or pollutants coming from the highway next door, or whether there's been some stimulus that we don't even know what's happening with regards to an upsurge in asthma. That's a public health opportunity, but it integrates well with looking at individual components of how people are keeping healthy or suffering from disease.
So, Ryan, when I think about culture change, I think about children, and actually some of the work that you've done. But, one of the things that's been happening is that there's been a major effort to change the culture around health in schools. And, my daughter, who's a millennial, can't believe when we're watching an old movie that, people are picking up a cigarette and lighting and smoking, because that's something that to her is completely antithetical to anything that anybody she knows does. But now in schools, we're succeeding in many communities across the country to change the food that's available in the school, to have healthy foods in the school, to get rid of the heavily sugared foods. The amount of sugar in some of the drinks is just astounding, And also to reinstitute recess, PE, real PE that actually keeps children activated, not, PE where they're standing around waiting to be picked or waiting to go to bat, but real PE where kids are really moving and really active. And we're going to have another generation, the post-millennial generation, that will be taking it for granted that that kind of food availability and availability of physical activity will be available in colleges. We're already having to respond to that at my university. Our students expect to have different varieties of food available now. They don't want to only have, the fries, burgers, hot dogs kind of thing. That, my generation, certainly me, I got through college on pizza probably. And, and the other thing is that they expect to be able to be physically active. They want to be very active. And they'll want that in the workplace as they're leaving college. They don't want to drive an hour a day to get to a job in the way that other generations have been willing to do. They want walkability. And these are all good things, but I think that as we've changed this with kids, we're beginning to bend the curve with the obesity epidemic. We're just starting to see leveling off of obesity among children, which is wonderful news. It's probably the first piece of good news I've given you today. And not that the rates are going down yet, but I think that we're on to something here, which is that we can impact this obesity problem with children before we can with adults, that's where we need to start. And so that that's another thing I think to be aware of, and that is that younger people are simply going to begin to expect these things.
Yeah. It's really promising to hear that. I mean, the thread that just happened across the panel was some uplifting news finally. I mean, I heard about consumer demand for health, and that your customers are taking you up on this availability of this app, and there's some culture change happening in workplaces and your students. I work right by your campus, so it's affected the lunch options available to me, because all of these places have popped up around your campus, which has been fantastic. As this generation works its way through the workforce, is that going to catalyze us to do more, you think, in public health? I mean, is this generational shift a promising sign? And I know that there are communities that are, it's a broad brush stroke. Winston is going to his disparity lens. I can see it.
Yeah, well, I think it's hard to predict the future generation, isn't it? But I think this generation, it's like post-millennials, are obviously much more socially connected virtually than any of us ever imagined in our childhood. So I think that's defining communities in a different way. So it used to be communities were pretty much framed within a geographic context, which I think still has viability. But I think increasingly people are connected through thousands of miles, seeing that we have a common life experience that we can activate. And hopefully it's activated in terms of how people realize individual positive outcomes, but also community positive outcomes. So I think even, for example, this transgender question that's coming up, and it's really been accelerating over the last couple of years with Kris Jenner, et cetera. It is a community that is not waiting to have policies come down. They're defining their own policies. So it's not public health, but I think it's an example of how the social community is accelerating changes. And I think we'll probably see that over the ensuing 10 years as it expresses itself in community and public health.
You know, in 2009, the Wall Street Journal reported that the fastest growing major in the undergraduate environment was public health.
Really?
And I was stunned when I read that. And I thought, gee, what do these young kids know about the world that I didn't know? Because I didn't find out about public health until after I'd finished medical school and my residency. And then public health kind of came and hit me in the face, and it was the right place to go. But here are very young people who are connected with issues around the world, which is the big difference between, really the big difference between my reality at their age and their reality. And they just see that there are bigger problems that they want to solve, and they want to look at, and they want to think about, and they want to connect with. And so that public health interest was really very hopeful for me.
I'm going to just be a moment provocative and maybe pessimistic. I hate to
we
rain
were
on
heading
the parade.
up.
Yeah, we were heading up, but you know, when we come back to a passion we all have around obesity, and you see obesity in children, and how the norm now is to be overweight as a child and to become obese as an adult. And that's probably the biggest macro threat we have to the health of our society. And I know there's more healthy food in schools, and we are trying to get people to exercise, but until we crack that code, we have a tsunami of illness and lower productivity facing us, unless we find some way to deal with that. A lot of people are working on it from a public health standpoint. There are some innovative technologies that are emerging to try to tackle it, but it is it is the fundamental threat, I think, of young people, that so many will grow up to be obese.
And I think we're really seeing that it's a multi-pronged issue, but that there are a lot of things that we can do that can make a positive impact on the obesity in children. And I talked about the things that they're doing in schools, but there are other things that we need to do even prior to kids going to school. We're already seeing changes in the advertisements directly to children during children's TV. I had been unaware of this as a pediatrician, a public health person. When you look at the ads, you realize that this is very clever. Highly sugared foods with, you know, all their favorite cartoon characters and all the rest of that right there on the screen during times when children are in front of the screen and no adults are there. And sucking them into, I want to eat that, I want to eat this. And that is being taken on head on from everybody from, you know, Congress to the White House, the public health agency. All of us need to take that head on because we know that they wouldn't be doing that if it didn't work. That has to be market tested. That has to be, you know, it has to be something that's working, or they wouldn't be doing that. And it certainly is not what we want, you know, for the health of our children, that they become so conditioned to highly sugared foods, highly salted foods. That's something that stays with you, unfortunately, for a lifetime. So, but I think the other way that we can look at this is that, and you know, Winston mentioned the social media thing. We also increasingly have those kids connecting on social media. As a parent, this is something that I found to be kind of scary. My kid's a 19-year-old millennial, and the amount of connectivity that she has with people all over the world and has had since she was about 15 years old is unbelievable. But on the other hand, as a public health person, we can start to understand how people connect in smaller groups and perhaps use big data, some of the same approaches that people who do marketing for products use to try to understand what is actually motivating, promoting some of these behaviors. What are the identity circles that people belong to? Who are the people that they communicate with? Who do they respond to? What are the messages that they're receiving? And how can we begin to shape healthier behaviors? We do know, for example, with smoking, that the people who still smoke are in a separate set of social networks than people who don't smoke. People who smoke, their friends also smoke.
There was a Seinfeld episode about that.
Is there really? Yeah.
I'm kidding, but there was.
It would be a good Seinfeld episode, and we need to start using those data to kind of to try to crack the codes, if you may, that exist in those networks and figure out how do we help that remaining 17% of the smokers who really need help, for example.
Well, you know, Lynn, you're exactly right on the marketing side, and you know, this is something that I'm passionate about. But we can do all we want to make available and accessible healthier options. But when the marketing messages that are bombarding our kids, and we know that less than 1% of the $1 billion spent on food marketing every year is for fruits and vegetables, which consensus, you know, science says should fill half your plate. And I've told this story before, but I do this for a living, and I cannot get my own son to eat vegetables. And one night I was just exasperated, and I said, Bud, what's it going to take? If it's not me, who would convince you to eat your vegetables? And he essentially looked at me and said, LeBron. and I knew from work, LeBron had a lucrative Sprite contract, a McDonald's contract, and that's what the start of this effort we made to get celebrities to actually endorse the products they eat, not the ones they get paid the most to endorse.
Isn't there an economic issue here, though, too? Because we all know this. You can get a high-caloric meal for like $3 at McDonald's, but if you don't have a lot of income, to buy healthy food is much more costly. And we all, probably everybody in this room spends a lot of time in airports. Even educated folks, like in this room, very accomplished people. What's the longest line in an airport for the food establishment?
McDonald's.
It's McDonald's because it's fast, it's high calorie.
Chick-fil-A.
Chick-fil-A is pretty up there, right? Where the salad bars are not necessarily, you know, lined up around the block.
Right.
So I think this issue that it is education, but there's an economic issue. It is more costly to eat healthy.
Absolutely.
Well, I think the other interesting aspect of, and I always say obesity is not just a question of caloric intake and caloric expenditure, and you touched upon it, Harry. It's also about how people relate to food.
Right.
Okay. So I think everybody here likes sweets to a certain degree, or likes certain comfort foods, as we call them, because they have a really strong psychological link towards feeling more secure and comfortable, and probably having some hormone release as well. People know this from a neuropsychiatric perspective. Now, I think what's also happened, going back to your point, Harry, very early on around mental health as an issue for Americans and probably, dare say, most of the industrialized countries, we find that children are experiencing bad psychological trauma early on. Mm-hmm. And to ameliorate all those emotional effects, part of the comfort is reaching for something that feels familiar and something that releases a hormonal set of cascades that enable them to reach a level of, I'm not so much in danger. So if you're a kid that grows up in a community not so far from here and hears gunshots from time to time, and it's not a big deal to you, you become so attenuated to the gunshots, reaching to, you know, that critter in the package offers you some psychological comfort. So I think it's not just a question of what we're putting in our mouth, but what that nutrient or semi-nutrient does in terms of alleviating some of the emotional impact that we're seeing among young people and whole communities. Mm-hmm. So it's a very complex web of how we're getting to this state of people really eating unhealthy foods, not just a question of caloric intake. Mm-hmm. Mm-hmm.
Yeah.
If you could take this group of leaders, I can't remember how many folks are here, 3,500, I think, at Global Conference, leaders from all sectors from around the world, and do the sort of proverbial grab them by the shoulders and shake. Listen, man, this is what you got to do, man, woman. What is the one thing, if you could just make an ask of this group, what's the one thing that you would ask? What's the one piece of wisdom you would leave them with? It's a big, giant question. You can take it anywhere you want.
Well, maybe I'll start. It's coming from a big company, and we talked a little bit about this in a roundtable yesterday with some CEOs that are here. I think employers taking responsibility for ensuring and promoting healthcare of their employees and is absolutely critical. The one thing employers can do, especially bigger employers that are self-insured, is they can have absolute control over, and this is an area you've worked a lot on, Winston, benefit design. You can make it so that it is easier to get preventive services, that co-pays are lower, that you get credit for going to gyms and the gyms are free. If you cover your own employees, you can do very, very creative things that you can't do if you're not taking responsibility for self-insuring and managing the risk of your population. If you're a smaller company and you outsource that, so to speak, to an insurance company that then manages it, you still can influence what they offer. It's just not as strong. But I think employers have to be proactive. They have to be in the game of promoting healthcare, and they can be there are some people here at the conference, like Stephen Bird, have been very, very creative at benefit design to make it economically compelling for employees to do the right thing around healthy behaviors, exercise, getting into weight loss programs, quitting smoking, those kinds of things. So I think we have a great opportunity, and it shouldn't be just looked upon as a benefit that you negotiate once a year.
Right. Carmen?
So I would ask everybody here to take a minute and to think about what they do every day, whether they run a business or they're part of a community, to think a little bit about what is the nature of your work and what is the one thing you could start with that would really link to a positive health future for yourself, for your employees, for your community. Talk with your family about it, talk with your colleagues about it, talk with your employees about it, and try to figure out where you could have an impact, because really, it's not about us up here. It's about all of us together. And so I'd ask you to define what your role is and engage that role.
Winston?
Well, I've been toying with this notion of, many of you probably have heard the term population health. Actually, the definition of population health is bandied around a lot in public health as well as in medicine. There's also then the world of public health. And public health, as we discussed today, I think has really changed from really infectious disease, occupational hazards, now towards looking at chronic disease prevention. I'm really toying with the idea of whether we introduce the idea of populist health, which populist health is really trying to identify that there's a certain current in the community that spontaneously and organically identifies what is risk to their individual health as well as the community's health. So to Lynn's previous slide that showed the 2 water samples, I think the community in Flint knew that they were drinking poison for many, many years, but no one took the time to really listen to the population and the communities there. I think if we really invest in populist health, meaning that the communities themselves have some inherent and intrinsic knowledge about what is risk in their community and to their families, we'll do a much better job of navigating the 21st century with regards to chronic disease and mental health, and as well as issues around workplace environment.
Lynn?
I would say to be a leader in whatever realm where you work. I think that that could be being a leader in the schools in your community, with changing the way that schools actually, feed children, provide physical activity for them. It could mean being a civic leader in your community around issues like the drinking water, parks, and other ones. But it could be within your industry being a leader and shining a light on ways within your own industry to create a healthier workplace for the people who work for you, to create better health plans, to work with some of the newer health plans that are much more focused on keeping people healthy. And I see huge economic benefits from all of those in terms of the health of your employees, the fact that good workers want to live in good communities, the fact that we're paying so much for healthcare insurance.
Thank you. We want to give some time for questions and answers with the folks here in the room. Do we have a microphone that, okay, ma'am?
Hi, I'm an employer in Milwaukee, Wisconsin, and when you guys think of Milwaukee, Wisconsin, you probably think of a nice Midwestern town with great values. And we are that, but we are also one of the worst places in the country to be an African American.
Yes.
And that's directly correlated, as you know, Winston, to economic disparities and all of the the increased violence rates and the poor healthcare outcomes that go with that. I'm an employer. I'm a member of the business community, and I am consistently trying to engage our chambers and my peers in this dialogue, but I find that it's very frustrating around public health to grab onto a metric that isn't super macro like life expectancy or super micro like maybe heart disease rates. Right. So I know the values of our city, and I know we want to make progress, but it's been very difficult to kind of camp around a common set of a common agenda. So do you have any experience that you can share on metrics and also other cities that have succeeded?
Well, let me take an initial shot at that. As Kaiser Permanente, we are obligated under actually Obamacare, the IRS, to produce a community health needs assessment for every area in which we have a hospital. And actually, we've expanded that expectation of ourselves even beyond hospitals. So you have something actually called the community health needs assessment. And the community health needs assessment encompasses all these different parameters. I would encourage you to, in Milwaukee, to look at what the community health needs assessment has been for those hospitals that are nonprofit and see, and they're public domain. So those hospitals should be accountable to identifying what those needs are and then whether they've been able to make significant progress over a 3-year period. Now, having said that, sometimes those metrics are still somewhat hard to get at. What we've been trying to do is to look at things like how do we change the food environment and whether there's indicators to suggest that certain communities are getting a level of intensified efforts with regards to promoting healthy behaviors, having environmental places in which people can walk and bike, et cetera, and associate that with some improvement in terms of just the conditions in which people live in. And we can talk offline if you kind of would like to look at a bit more in terms of how we're identifying how we're being able to meet to a certain standard of investing in communities.
You know, when I used to work for a city, one of the issues that came up for us was that we had 2 heart attacks in fairly rapid, fairly rapid progression of the guys who take the money in the ticket booths when you're coming out of the parking structure. And the city manager called me up and said, "What is this about? What is this about?" And this was, way back there. And nobody had really thought about what kind of exposures were these guys getting. Finally, they figured out that there was a relationship between the carbon monoxide and cardiac function, and how do you link that together? So they took the guys out of the booths, and these were fairly low-paid workers, took the guys out of the booths, made them automatic, and that, that particular aspect of workplace illness went down. When I first went over to Public Health Institute, I came in after lunch one day, and the secretary says to me, "We got this call, and I just don't know what it was, but it's a group of businessmen from Riverside, and they want to know, is there anything you can do to prevent girls from getting pregnant because it's killing their businesses? They're having to retrain. They're just having to retrain." So part of this is, when you've seen one city, you've seen one city. But for your community, you might just try, in a conversation with your colleagues, trying to come to what's the one thing that you could look at, or maybe the 2 things, where there was something that could be addressed that could change either job turnover or illness and disease. And those are 2 examples of things that can be done, but it takes a little bit of observation and a lot of talking to one another in order to figure out. I love the fact that 3 businessmen called up and they said they wanted to know what could be done because it was killing their businesses. These girls were getting trained in and then they had to leave. That makes you crazy.
So I have a suggestion as well. There's a fairly new School of Public Health at the University of Wisconsin, and one thing that could be an option would be to partner with them. One of the things that we like to do when we are tackling an issue like that with communities is we like to set up a participatory process where members of the community work in concert with academics and also community leaders. And sometimes the members of the community have a lot of wisdom about what's going on, like the lady from Flint who's holding out the contaminated bottles of water. She knew that there was a problem, and oftentimes members of community are very, very astute about spotting what their problems are. And you need to set up a forum that's a neutral forum where they can have a voice and be listened to. But that being said, there are some metrics that change very rapidly that are always worth looking at, in my view, and those have to do with the health of infants. That birth weight and preterm birth and infant mortality can change very rapidly if we change conditions for health. It's not like the development of diabetes and cancer that takes decades. And that we do see a lot of disparities in those measures where you have unhealthier communities. One of my colleagues who's here in the audience, Tom Leviste, has particularly worked on issues like this in places like Baltimore, which are very similar, and has seen that in African American communities in particular, it's not so much the race of the people in the communities individually as the degree of segregation and the degree of poverty in the communities. And those are statistics that you can see that the census collects and are also worthwhile looking at. And so I think you could take a combination of approaches where some of that basic data comes together, but then actually have a process where you bring in the academics, the community, the business community. You'd be surprised about what you can learn from that.
Do we have another question? Yes. Front row.
Good morning. Thank you for your time. A lot smarter than I am on healthcare, but I appreciate everybody's perspective. Active duty Marine stationed at the Naval Academy. We have a different perspective of healthcare. We actually go to the extreme, which is kind of interesting. We have our own problems. About 7% of the force is actually unable to deploy because of health issues, and that's because we break ourselves or have nutrition issues. I was a little bit more curious, Dr. Wong, and anybody that wants to answer, linking technology in with healthcare. Is that an ability that we could do that in the near future where your health insurance is actually caused or correlated to how much you are doing healthy? Because really interested by Walgreens, but you have a lot of statistics, doctor, about like how we could do that. So I didn't know if we could actually decrease health insurance or costs by actually linking in with these new Fitbits, Jawbones, or something more integrated that's linked DNA-wise, that you just can't hook it to your dog and your dog runs steps for you and you get credits for it or something.
Right.
Thank you.
Yeah, I think it's very intriguing, and at Kaiser Permanente we are trying to link technology more into the traditional aspects of being an insurer and a provider. Now, having said that, I think there's still a lot of science to be known with regards to who's actually using these devices. You know, here he mentioned their success at Walgreens, but we have some data that suggests that people who start Fitbit, that at least 60% of those individuals don't use them after 6 months. Right. And it might be because the technology wears out, or people just get tired, or there's... the other aspect of this is that we have an insured population that scales from people who are well into the wealthy segment of the population to people who are barely just making ends meet. So we don't know, relative to the different swaths of people, if you segment them across social gradients, how much uptake there is going to be around these kinds of self-monitoring technology. The other aspect, which I think we also need to investigate, is how much people feel that this is being invasive with regards to their personal history. And there is probably, suitably so, a certain amount of anxiety about a health insurer knowing every aspect of a lot of your health behaviors, and whether that invades into privacy aspects. So I think this area is still kind of wild, wild west. The technology is very intriguing. In fact, we have one technology that we're experimenting with, and Walgreens is probably involved in this, that we have a medicine bottle that is able to monitor whether the individual is actually using their drugs, because every time they open up the container, we can get a message with regards to whether that person is using their medications, and adherence is the big issue. So technology is very intriguing, but I don't want to kind of promise something that has a lot of social implications, as well as really understanding that when you come down to the core of it, you're still dealing with human beings and communications and relationships. Dare say a clinician-patient relationship is at the core of a healing relationship.
I have a slightly different take on this that might be useful to you. For several years, I was working with a group called the Military Health Futures Group, and it was convened by the Surgeons Generals of the Armed Forces, and hundreds of doctors and military folks in the room. And what we came to was a pretty good understanding of the fact that the people that were really most at risk were the people who had not come from military career families, but actually were the people who came to the ranks because it was the job that was available. And where do they come from? They come from the communities that are immediately surrounding the military installations. Okay, I grew up in that kind of a family. And when we were stationed at 3 different bases, and the problems were really similar. I mean, the housing was, the income was, and these are the communities that don't have good exercise, don't have good food choices, and in fact have pretty high rates of diabetes, et cetera, et cetera. So where we came to as a conclusion was that the military needed to become more engaged with that surrounding community to try to move towards a healthy community model, because since they were going to get folks from there, they may as well get them from a community that really valued their health from their growing up stages.
Yeah, one real quick comment, because I know we're pressed for time, but I think Winston raised a good point. I think when it comes to monitoring through technology or any sort of data, an opt-in process where people can say, I want to do it, versus a mandated process for an insurance company has its advantages. And yeah, there's always this risk that people are, putting the Fitbit on the dog to get the miles. But the reality is most people aren't doing that. And the technology is advancing to the point where the newer devices, the next generation, will be that you can distinguish between your gait is different than my gait, and it'll be able to tell that you're actually using the device versus someone else. And then the final point I mentioned earlier is I really believe putting incentives into people tracking their data so that it's something they get rewarded for is a powerful part of the equation. But if we wanted to take this to extreme, I had a lunchtime conversation yesterday with a group of entrepreneurs, and there's the ability to link data from purchases, what you buy in stores, your activity, your credit score, your zip code. We were just kind of thinking about, wouldn't it be great if you could create a total wellness score that incorporated lots of behaviors, your exercise, what you purchase in the store, how you manage your life. It would have a lot of scariness around invasiveness, but if you could opt in, like putting that thing in your car that lowers your car insurance, if it monitors how you drive, what if you monitored your own health score, you got a lower premium? I mean, I'm just thinking out of the box here about how we could go somewhere in the future.
Or you pick up that bag of chips and you get a text message that says, "Don't open that," you know.
Unless it's a Walgreens.
Unless it's from you. No, you know. But I mean, this kind of opt-in, opt-out thing, you know, in the private insurance market, it's been suggested that perhaps one way to go, and some companies I think are looking at doing this, is that somehow you charge people for their insurance based on their risky behaviors or lack of them. And that's very controversial, but it's certainly something that we do with automobile insurance all the time. You know, we have good driver discounts. There's even a good grade discount. I know about this because I have a college-age kid. And should there be discounts for people that have healthier behavior? And the problem is that, as we've already discussed, that a lot of people who have less healthy behavior actually are poorer, have less money. And what we wouldn't want to see is that perversely, we wind up that those people then don't insure, are not able to afford their insurance because of the fact that, you know,
basically a regressive tax.
It's a regressive tax. And then at the end of the day, if they get diabetes, if they're unhealthy, we're going to pay for it anyway through Medicaid, Medicare, you know, through tax revenues. And so it's not necessarily going to get us to that place. But still, you know, I think that we have to figure out how we create those incentives. And I actually might be one to say, yeah, it ought to be your mama's voice on, you know, your iPhone saying, "Don't eat that." But we do need to become, we need to be smarter about how we provide feedback to people. We need to be a lot smarter about how we do that.
We have time for one more quick question.
Is the one over here?
Here we go.
You talked about 1 in 5 individuals have mental health issues, 42,000 suicides a year, 200,000 other folks who are hospitalized because of a suicide attempt.
Right.
Yet we have problems with a mental health parity bill that was passed, I think, in 2007. The final rule came out last year.
Right.
What else is it going to take us to move in this area?
Boy, I'd love, since I brought it up, I'd love to take a quick hit and then see if other people have comments. I'm so glad you asked that. I mean, there was a bill passed, but it's not being implemented in the way we would like. I was very, very fortunate to be at a dinner last week hosted by Patrick Kennedy, who has made very public his struggle with mental health problems and addiction, and wrote a book recently called A Common Struggle that I highly recommend. And I think it's advocacy. I think it's the kind of work that Patrick's doing through his Kennedy Forum. It's companies and leaders in the country should push for this. I think there needs to be a political movement to really make sure that the mental health parity is really driven through our culture, where a brain disorder, a brain illness like depression or anxiety or OCD, is treated no differently medically from an insurance standpoint and from a stigma standpoint as having hypertension. We've got a long way to go, and I think there's got to be a crusade around it. And I was very inspired by Patrick's vision and leadership on this.
Yeah, there is a global effort underway. Last week, we hosted at the George Washington University a meeting of the World Bank on the issue of mental health globally. And people are beginning to appreciate that this is a huge burden of disease, not only in the US, but also worldwide. And in fact, that in some ways, this is hard to realize, in some ways we're doing better than many other nations. We're not doing as well as Europe in terms of actually mainstreaming mental health treatment, preventive care into the fabric of the healthcare system. And that's what we need to do. It's still off on the side, and the Parity Act well-intentioned,
And I don't know all the details,
think it had the
but there
teeth.
are some major bills coming before Congress this summer and fall to try to move forward on some of this.
You know, it's very interesting. I think the whole mental health area is, as I understand it, it's a national conversation. But again, there's this two-sided coin. One is mental illness, which is really focused on making sure that mental illness comes out of the shadows, so to speak, and people are much more willing to speak to their providers. But there's the public health, mental health, and mental wellness that we need to get our handle on. I don't think public health, or our country in general, has really dealt with mental wellness as a public health issue, and we need to create that space.
This is also someplace where we have to take, a page from the playbook of HIV and AIDS. It's not easy to talk about, but we have to make it a campaign. We have to make it an issue that everybody gets lifted up and really makes it part of something they're aware of and connects to where it impacts them, their families, their community. It's my issue. It's not that person's issue. It's my issue.
Well, and just one last point. Everyone in this room, if we had a cup of coffee, has a story about a family member or themselves. It is very personal. We all have these stories.
That's right.
We are out of time, but thank you so much to all of you. It was a good discussion. Thank you.